Hello, good evening, everyone. This is Dr. Praveen Gangadhara, consultant at Dr. Mohan's Diabetes Specialty Center, Malleshwaram, Bengaluru. Good to be back on one more episode of FB Live. Today we have an important topic. I think most of you are following the page would have come to know by now. Is diabetes only a danger sign for overweight people or with obesity? Uh, it's an interactive session, so I'd be happy whoever have joined in can post your questions. I will brief about the topic as well as whatever questions you're asking in the chat box. I'll try to answer as much as possible over the next 30 to 40 minutes. First of all, why this question? This is an extremely important question, and these are some things which we generally our patients do ask us during our consultation. I'm obese. See, people who are already obese try to who are on the higher side tend to ask this question, and sometimes people ask, "I'm extremely lean. Why did I get diabetes?" So both the extremes, you do get the questions. So before we understand about what is this overweight, obese, or normal, we need to understand what is. I think most of you are aware of this term called BMI or body mass index. So I think everyone's aware of. I think you go, you check your weight, you go anywhere, and even in the restaurants, people tend to check their weight, but they don't understand what is their correct weight for their height. That is why we need to understand what is normal BMI, what is overweight, and what is obesity. And again, these cutoffs are pretty specific for Asian Indians. I think we all belong to this ethnic race of Asian Indians, and these cutoffs are slightly different when compared to the Caucasians or the white people or even the blacks. I mean, the most of the studies, if you talk, are seen in the white people, and the Western cutoffs do not generally apply for our people. So let us first understand these cutoffs. I think once you understand, then you will know where you exactly stand. So if you talk about the BMI in particular, nothing but that is body mass index. You get it by dividing your weight in kgs by height in meter square. So when you do this maths, I think you would know where you stand. And what you call as normal BMI for Asian Indians is between 18 to 22. Because this again, if you talk about the Western guidelines, it's slightly higher. So between 23 to 24.9 is considered as overweight, and any BMI more than 25 is considered to be obese. So this is slightly different when compared to the Western cutoffs, where the cutoffs is you up to 30 is generally considered as obesity in them. Apart from just the BMI, one more important factor in Asian Indians is what we call as the waist circumference, or what we measure your abdominal obesity. So along with BMI, it's also important you know what your waist circumference is. And again, this has again for males, you have a roughly of around what you call as 90 centimeters. It should be ideally less than 90 centimeters or 32 inches. In females, it should be ideally less than 28 centimeters or 28 inches or 80 centimeters. So BMI along with the waist circumference or the waist hip ratio is more specific, and that gives a better idea for not only for diabetes but also for your overall cardiometabolic risk, that is even your heart related issues. This BMI becomes a very important factor along with your the waist circumference. So these cutoffs, when you compare with the Western population, is slightly more stricter. It's not that you want to make all the people obese or don't want to make all the people overweight, but we have observed that even in Asian Indians, these people are at higher risk even at a lower BMI cutoffs. Also, they tend to, even a person BMI may be 24, but still that person tends to have a higher abdominal obesity. So your abdominal obesity or the waist circumference plays a very important role, just not only for your risk of diabetes, but also for your, as I mentioned, for your heart diseases, fatty liver, bad cholesterol. So all those, what you call the metabolic entities, more or less, they are interrelated. So it's very important these things are kept in our mind. And again, if you ask me why is it so, because Asian Indians again genetically are predisposed for these metabolic disorders. But again, with various factors at birth itself, be it the low birth weight or the environmental factors, or again the other factors, mainly with our consumption of carbohydrates, which is pretty high. And when I say again about carbohydrates, I keep telling in most of the talks that it's just not about the rice, which is considered the white rice. You consider all the other cereals too. In general, if you consider our carbohydrate consumption is on the higher side when compared to the Western counterparts. In general, our carbs is around 65 to 70%, or sometimes even more than 70%. And again, intake of more of refined carbohydrates again predisposes you to have this what you call as the abdominal obesity, or in general, just like an epidemic of diabetes, even this epidemic of obesity is also a concern for all of us. That is why it is not a very rare phenomena to find people less than 30 years, the childhood onset type 2 diabetes we call, even children who are obese are at slightly either pre-diabetic or obese, and on the higher side. And that is one of the main reason why that early type 2 is also a common feature. Apart from that, we should also know that when we talk again more specific about only over people having at risk of diabetes, a lot of studies, especially from our own institute, we have had this clustering of type 2. So when you talk about diabetes in general, we all know that there are, I think in general, if you broadly classify, people talk about type 1 diabetes, which is generally seen in the onset is generally in the children age group, and are insulin dependent. Then you have the type 2 diabetes. Then you also have the gestational diabetes. But again, when major cases, and most of us which we know are, we talk about type 2 diabetes. The type 2 itself has subtypes, and again among the Asian Indians, you have this clustering to the subtypes of type 2 diabetes. And again, BMI here also plays a very important role, and each subtypes have a specific risk factors, as well as their metabolic characteristics are slightly different. So let me speak about those subtypes as and when we can see. But I'd be also happy to see if any questions are being asked in the chat box. Okay. I'll wait for the questions. I think few questions are being asked. But I think before we start about the questions, I can even talk about your subtypes of type 2 diabetes, which is again very important. So again, as I mentioned, type 2 diabetes is what we generally see. I think most of our patients would be knowing that they generally respond to oral anti-diabetic drugs or the tablets. Later on, they may require insulin if their insulin reserve comes down. But again, if you talk about the type 2 diabetes, you do have various subtypes. So again, here BMI plays in kind of important, because what you call as the classical type 2 are generally considered to be on the obese side, or the BMI tends to be on the higher side. Because of your higher BMI, the overall insulin resistance is on the higher side. So obviously, insulin resistance would put more pressure on your pancreas to produce more insulin. And over a period of time, when this compensation fails, people tend to develop diabetes. Same way, so when you call this clustering, or when you divide the subtypes of type 2 diabetes, you have what you call as uh, lean type 2, or what you call as the severe insulin deficient diabetes. So even in type 2 diabetes, you can have somebody who is lean, whose BMI can be as less as 22, 21 also, still can have severe insulin deficiency. So that is one thing. So again, why is this important in somebody who is severe insulin deficient diabetes? These people would require secretagogues, or you may require insulin in near future. And these people's BMI, if you see on a in general, the BMI would be around 22. And if you look at the inspired study, if you look at the INDIAB data, even in the nationwide data, the mean BMI was around 22. So again, when you talk, 22 is considered to be a normal BMI. So again, the question of asking only, is it if you're overweight, will you develop diabetes? No, not exactly. Even if somebody is lean, you can have a secretion defect. And we know that Asian Indians do have more of a secretion defect than insulin resistance. So that is one subtype. Then you have the classical type 2, what you call as insulin resistance or obese diabetes. That is the iroid type. And here, classically, you would see patients requiring the sensitizers would really work well. And obviously, weight loss would definitely help them in preventing the progression of diabetes. Then you have other subtype which is very specific for our Asian Indians, what you call as a combined insulin resistance as well as obese. So you have both insulin resistance as well as combined insulin resistant as well as deficient. That is these people have both insulin resistance as well as insulin deficiency. So this is more because it's more of a combined feature. They are more their progression can be more faster, and obviously they're at more risk of more of these microvascular complications and diabetic kidney disease. So then you have the last subtype, which was again similar to the Western study, what you call as the mild age-related type 2 diabetes, and these are generally well controlled. You would see this plus 60 years, even a small dose of metformin or metformin with the gliptins or the DPP4 inhibitors. Generally, they tend to do well, and it's generally more a silent subtype and which can be controlled. So even in type 2, as I mentioned, you have these subtypes like lean or severe insulin deficient, where the BMI can be less. You have the obese category where the BMI tends to be on the higher side, more than 25, and you have the combination of both this. The lean as well as the what you call as the severe insulin resistant as well as insulin deficiency type of diabetes. But what is the take home message? I think one of the question being asked is similar to that, and as they have mentioned, I think this is a question from K. Dhanlakshmi. Namaskaram, doctor. Is insulin resistance to develop diabetes, is it reversible? Okay. Is insulin resistance need medications? Okay. Okay, I'll try. I didn't get the question completely, but I'll try to answer. I think you're trying to ask, is resistance developed required to, okay, is insulin resistant need medications? So if you talk about resistance, I think the insulin resistant type of type 2 diabetes or the classical type 2 diabetes, we use the first line therapy generally considered to be metformin. And metformin is an insulin sensitizer, and metformin tends to bring down your insulin resistance. The good news for people with insulin resistant subtype is if they have a healthy weight loss, if they can bring down few kilos, definitely, as she has mentioned there, saying that today is the world of today, the hot topic or the trending topic is about reversal of diabetes, or the correct terminology is remission of diabetes. So among the subtypes of diabetes, like the severe insulin deficient diabetes, or if you call the combined insulin resistant as well as deficient diabetes, the obese category, the thyroid type or the insulin resistance subtype, slightly are better off, because if these people can reduce their carbohydrate intake, have some sort of a healthy weight loss, some sort of partial remission, especially if your duration of diabetes is less, if you have a good C-peptide reserve. What is C-peptide? Nothing but your beta cell reserve. If this beta cell reserve is pretty good, you can have a partial remission, provided you try to stay there. So that is more important. Again, obviously, if you're trying to gain weight, again you will put on, or your HbA1c can come back. So if you lose weight, obviously there is chance of partial remission of diabetes, and this is much more possible in this obese subtype of type 2 diabetes. Okay, so there's one more question from Mr. Madhusudan. Hi, doctor. If a diabetic person maintains his HbA1c under 7 throughout his life, will he develop any complication? What are the parameters to watch out for avoid progression? Excellent question. So I think this is an excellent question which can address multiple things here. So we generally we say glycemic targets or your glucose targets need to be individualized, but in majority of the people, as Madhusudan has mentioned there, it's good if you can maintain HbA1c less than 7%, which is considered to be ideal. Obviously, younger the age, you try to be a little more strict or a little more stringent. You can even aim 6 to 6.5 or between 6.5 to 7 without causing low sugar or hypoglycemia. And if you're able to maintain the HbA1c less than 7, obviously your risk of both microvascular as well as macrovascular complications. So that is what is microvascular complications? That is nothing but your retinopathy, nephropathy. Retinopathy means something related to your eyes. Nephropathy is related to your kidneys. Neuropathy is related to your nerves. So your microvascular risk definitely comes down by 25 to 30%. So there are a lot of studies, the landmark trials, which have shown that even 1% reduction in your HbA1c, just 1%. And if you talk about the newer concept of time in range, even a 10% increase in time in range can bring down your risk of complications. So if we talk about HbA1c per se, 1% reduction in your HbA1c brings down your risk of microvascular complications almost by 25 to 30%. And this is very much possible. And it's more important you do this early. So you are diagnosed probably a year back and your duration is less than 5 years. We also call something called as legacy effect or metabolic memory. So that is why bringing down your HbA1c at an early stage, along with your other risk factors, be it your blood pressure or dyslipidemia, is very important. And when you bring this down earlier the better. Your risk of developing any of these complications, what you call as the both micro as well as the macrovascular complication, almost brings down the risk almost comes down, and that benefit also stays after even in the future. Even in the future, if your HbA1c is slightly on the higher side, you're not able to control as you used to control before, even then you will be able to the risk of complication comes down. And lot of landmark trials like what you call as UKPDS legacy study, you have the other follow-up studies of UKPDS, DCCT, and these people have shown that the initial early intensive treatment has definitely has some benefit even after the study period was done. And that is why you draw back you get this message of the legacy effect in these patients. So that is one important criteria. And coming to the second part of the question, what are the how will you assess these parameters? So that is why we call what we call as complete diabetes care, or it's important to watch out for these complications. So in type 2 diabetes, it's very important at baseline. You apart from just the HbA1c and sugars, you also get your retina evaluated. Retina not only gives your understanding about your sugar control, it also gives retrospectively even your blood pressure control. Apart from retina, through your urine, you can check for urine microalbuminuria or urine albumin creatinine ratio. This again would pick up early. These are early markers for diabetic nephropathy. With respect to your nerves, you have your what you call as both biotheciometry as well as arterial brachial index, which can pick up either peripheral vascular disease as well as the signs of early neuropathy through these markers. Obviously, macrovascular changes, you would, apart from PVD, also belongs to macrovascular. You do have your routine cardiac evaluation with ECG or a treadmill test if indicated, along with your lipid profile and your other related parameters. So these are again basic parameters. So along with A1C, if you're able to screen these complications, you can again revise the target. So if somebody is having early non-proliferative diabetic retinopathy, we know that I need to be more strict in your sugar control, as well as if your blood pressure is above target, you can be a little more stringent in controlling these targets, so that we know that there is also a relationship between retinopathy and nephropathy, that is your kidney disease. So again, these are early markers, and when picked up early can definitely prevent in progression. And based on the which stage you are, you need to follow it up either once in 6 months or once in 3 months if it is extremely severe stage, or yearly once if it is normal. There's one more question. This greeting from one of my patients, so Veena. Thank you for joining in, madam. Yeah, she's the namaskaram, right? So there's a question from, what is the main problem associated with diabetes? Okay, so general question. I think most of you are aware of it. So it's not that everybody has diabetes, you will have complications. Something like we had a discussion during COVID also. So everyone who has diabetes would get COVID. So in general, if you control, even if you have diabetes and if you are controlling it well, you can be as normal as anyone else. Only problem comes with this uncontrolled diabetes, HbA1c more than 7, 9, 10. You continue to maintain this, then obviously you will develop those complications which I listed there. That is, be it your retinopathy or the eye problems or the kidney problems or the nerve problem. And the second question which commonly people think is taking medication causes these problems, but it's actually other way around. And I reiterate, and I want to make it again a fact that it is your uncontrolled diabetes and uncontrolled hypertension which is the leading cause for your chronic kidney disease, more than taking medications. Those are painkillers or NSAIDs, when taken over the counter without a doctor's prescription, can be harmful. But anything with proper guidance would not be a problem. But again, once you control these numbers, I think it should not be a problem at all. Okay, there's a question from Parmeshwari Subramaniam. Okay, there's a question from Parmeshwari Subramaniam. Indian diet is loaded with carbohydrates, so only carb counting, counting is not going to improve the blood sugar levels. HbA1c with diet, weight reduction is only 7%. I recommend exercises, slow graded static exercises, slowly increase strength exercises. So absolutely, I partly agree with that. But exercise is important, whatever age we are. Even elderly patients should have. And exercise doesn't mean just walking, as you rightly mentioned. There you have your the resistance training, the other aerobic exercises you have. So any form which is suitable for your age is extremely important. But I would put a point, and I discuss that diet is even more important. There are a lot of people who will exercise, but still they would say, and if they think that their exercising will help them for to lose weight or bring down their experience, exercise alone won't be enough. Diet, as you rightly mentioned, is loaded with carbohydrates. So diet is slightly 10-20% more important. Restricting your carbs would definitely give you slightly better results, because a simple example is you may still do a normal walking for 25-30 minutes, hardly burn 55, 60, max 80 calories. And that 80 calories is nothing. You come back and again have binge two idlis and one vada, you are at 280, 250, 280 calories, especially if it's outside food. So again, keeping watch both on exercise, apart from just exercise, food is extremely important. And when I talk about food, the cereals in general, the carbohydrates is burning them, keeping that count is also important. But again, we need to, more than telling it as carbohydrate counting in layman people, I think we should give them those, somewhere we need to individualize and make it simple for them to understand. Because most of the information is more generalized, and people assume, they tend to just change the cereals. Instead of having normal idli, they tend to have a ragi idli or rava idli, but they forget to include vegetables or the adequate protein in them. Same thing happens with the season of millets. Then they replace rice with millets. So this is the problem which majority tend to do. But the stress has to be on reduction of carbs and cereals in general, and along with that, regular exercise. It's not that you do 5 days, as ADA recommends. 5 days we do, and weekends we binge and we don't exercise. That's actually other way around. If you can have a sustained plan, 7 days a week, that would make more sense in achieving whatever the targets, whether for your HbA1c or even for your weight management. There's a question from Mr. Devarajan. Hello, doctor. If diabetes is more than 10 years, is it possible to reverse overweight? Almost BMI is 29. Okay, Devaraj. So that's a hot topic, reversal and remission of diabetes. So the good news, one, as I told earlier, uh, probably if your control has been pretty good all these years, and some amount of weight loss, I think this detail will not be sufficient, but definitely BMI 29 is on the higher side. So any weight reduction would definitely bring down the medication requirements or the insulin requirement. We don't know whether you're on insulin or tablets, but any healthy weight reduction would definitely bring down the requirement. Only reason why I'm not too confident about the reversal or remission is when you talk about 10 years duration, generally the beta cell reserve or the pancreatic beta cell reserve would have slightly come down. Even if you lose, if the beta cell reserve has come down by less than 50%, and how do we measure this beta cell reserve is what you call as a surrogate marker, or what you call as C-peptide. So you do both a fasting C-peptide as well as a stimulated or a 90-minute C-peptide post your meal. And if these level cutoffs are more than 70 to 80%, then probably with proper guidance and proper dietary plan, as well as the right medications, we can think of remission. But again, when I talk about proper medications, because there are few medications which can cause increase in weight, there are few medicines which can actually cause weight loss, and there are few medicines which can actually, apart from causing weight loss, has beta cell protective functions, like your GLP-1 analogs. We have the SGLT2 inhibitors, which again can cause aid to your weight loss. So apart from just the drug, a little bit effort from the drug, from your diet, then your requirement can come down. So remission, still a question mark without knowing your C-peptide levels, but definitely a healthy weight loss, because even uncontrolled diabetes can cause weight loss. So a healthy weight loss would definitely put you in a better shape in bringing down your insulin requirement or the medication requirement. So if you're on a little higher dose of sulfonylureas, we can bring it down. You can slightly do the different combinations. So these are the chances, but definitely you can put your efforts to bringing down the requirements if there is healthy weight loss. Okay, there's one more question. If we simply reduce our carbohydrate intake, this is from Madhusudan again. If we simply reduce our carbohydrate intake, significantly increase the protein intake, does this combat diabetes to some extent? Okay, so to some extent it is true, but again, the choice of your carbs as well as the protein is very important. Doesn't mean that you completely reduce your carbs. Never go into the extreme of diet because it is not sustainable. And when you talk about reducing carbs, ideally keep it around 50%. And again, the protein, what type of protein? Again, if you're a non-vegetarian, obviously the options for you is more. Whether you want to choose for egg white, chicken, fish, or whatever. And again, even in vegetarians, I think options are not bad. It's only that you need to be more conscious about what works for you well and what time you need to take it. That is also very important. So again, you can even include your healthy fat. Healthy fat is also a good choice in the form of nuts, some of the seeds. Definitely these things, the raw cashews, walnuts, almonds. These are also extremely good. Because once you consume these, the protein as well as the fat, automatically your consumption of carbohydrates will come down. A simple example is if you talk about the idlis, I think everybody likes to have idli with vada or idli with one more dish. Obviously, no hotel serves you chana or egg white, but if you can include some green gram, Bengal gram, especially if you're at homemade idlis, if you can include this and prefer sambar more with dal, that can again reduce your consumption of the idlis, and you can obviously increase the protein intake. So these are simple tweaking which you need to do in your diet, and you sit with our dietitians. I think you can have a proper plan, and that is not about having a chart, but something more individualized. Making the small changes would give you a lot of benefit in having a sustainable diet. Okay, so there's one more. There's a question from Jessica. Good evening, doctor. Can you please tell which organs are affected by obesity? I think almost every organ at one stage or the other would get affected by obesity. Obviously, with obesity, you would be at slightly higher risk of your. And as I mentioned, the Indians have increased visceral fat, the organ fat. People would have heard about fatty liver. Just like you do an ultrasound today, I think 8 out of 10 people would have grade 1 fatty liver. And I think again, people with abdominal obesity or generally even with obesity would have this risk. So there is excess fat accumulation in your liver, and even non-alcoholic fatty liver is a risk factor for liver. If it progresses, can cause liver cirrhosis. As I mentioned, obesity can put you at a higher risk of type 2 diabetes, cardiovascular disease, all your heart disease, coronary artery disease, hypertension, as well as in the later stage, especially in the postmenopausal women, obesity can cause knee pain, osteoarthritis, back pain. Also, it can increase your risk of fractures, especially if you have osteoporosis. So almost every organ comes in with obesity. So losing weight, not only just for diabetes risk, but having a healthy weight loss will definitely have a lot of advantages, not only to prevent diabetes, but also put you at a lesser risk of heart diseases, BP, all the other things I listed regarding your knees, osteoporosis, and fractures. Okay, there's one more question. Any national diabetes registry for T2DM is available in India? I think we have the non-communicable disease in the national programs. All the diabetes, hypertension comes in. I think soon, I think things are centralized. I think in coming days, we would have these registry, and I think the ICMR as well as the bodies forming these guidelines would have a lot of data coming in. Even what I was talking about, the subtypes of diabetes was from our ICMR INDIAB study. And that is when we are able to cluster these subtypes of diabetes. So this registry is there, but how we utilize this registry and how we prevent things, there's no more this urban-rural divide, and diabetes is not just a disease of the urban population. So these are some of the inputs we get from these latest epidemiological studies, and how we put into practice is very important in having the preventive measures. The other interesting question coming in. Okay, Afsa is asking, people doing intermittent fasting shows they show good control in diabetes. Can you please brief about this? So this is other hot topic on intermittent fasting. So again, choosing the right candidate is extremely important. So there are studies on intermittent fasting. Again, there are various subtypes of intermittent fasting. People tend to have a two-meal pattern. Sometimes again they skip the one meal, and there are the 3+1, the 2+2. But whatever you're doing, again, in people with diabetes, you need to again classify and see whether this person can is an ideal candidate for intermittent fasting. Now somebody is on insulin, twice daily premixed insulin, sulfonylureas, then with poor beta cell function, then intermittent fasting may not be an ideal choice, because again, adjusting his dosage, adjusting his insulin may become extremely challenging. Already diabetes is brittle. You want to do something and you'll end up with hypoglycemia, and again you may overeat. So again, choosing a right candidate is extremely important. If you ask me, the people who are pre-diabetic, people who are on stable dose of OADs, probably newly detected, and they're on medications which won't cause hypoglycemia, either metformin with a DPP-4 or metformin with an SGLT2 inhibitor, then in highly motivated people, intermittent fasting would give you some result. But again, you need to sustain it. And as I keep telling this, when you plan of running for a marathon or something, you should do your 100 meters, 200 meters, or generally the fitness, it should happen in a step-way pattern. So first of all, you should be able to follow a proper low carb diet, and you should be able to sustain it. And if you're able to do it, I think a two meal pattern does show benefits. But again, there are one more study which has again shown that you may have still three meals, and still the overall your carbohydrate consumption as well as calorie matters. You may still eat two meals, and if your overall calorie content is more, you may have two major meals. But if you have more snacks, again, if the calorie is more than what is recommended, then your intermittent fasting is not going to help you there. So choosing the right candidate is extremely important. And if you are having, as I mentioned, both pre-diabetes with obesity or diabetics, the duration is less than 3 to 4 years, and you're on a stable dose of oral anti-diabetic drug, definitely intermittent fasting is one option. But again, you have to discuss with your respective doctor as well as the dietitian, and then have a proper plan so that your dose adjustment can be done. And again, you need to see if you are able to sustain it. Again, a lot of papers have shown the other benefits of intermittent fasting. But as I mentioned, choosing the right person and the right team is extremely important to have a successful benefits of intermittent fasting. So there's one, is over exercising. There's a question from Nikita Sharma asking, is over exercising really safe? Uh, yeah, over exercising is also definitely, as I said, anything in extreme is bad. So even overdoing things, and just because again there is this concept, especially people who are newly detected, the youngsters, when they come, they have this perception. They moment they are diagnosed, they get into the extremes of diet, completely restricting your carbohydrates, increasing your overall physical activity. We tell 30, 45 minutes or 1 hour, that may sometimes stretch up to 1.5 hours. Sudden weight loss, anything extreme is definitely not safe. And obviously you can have more adverse effects because of these sudden changes, sudden weight gain, sudden weight loss. Any extremes of this normal physiology can definitely affect you, and is not generally advised. There's a question from Mr. Shankar Babu. What would you be the advice you give to control diabetes during travel, sir? Because I'm using insulin. Again, a good question. I need to eat also. Yeah, correct. So there are two things. So two things when you travel, the two major issues is, one is your calorie intake would generally go out, because you can never compare outside food calories to what you take at home. And obviously the timings can get deferred. And third thing is, obviously, if people are on insulin, it's always a kind of a tedious, it's kind of a difficult job to take it, as well as to adjust your dosage, and monitoring plays a very important role. So again, depends on the type of insulin. There are insulin like your basal insulin, which are once daily insulin. It's easy to manage, can be taken after meal. But again, people on twice daily insulin, especially the pre-mixed insulin, again, the timings plays a very important role, and there's some mismatch, you can land up in hypoglycemia. So first thing and foremost, it's very important, before your travel, make sure your sugars are under control, so that becomes more easier for you. So if your levels are under control, A1C is close to 7, obviously you have that little bit of grace period, even if the fluctuations happens, you can adjust. Second thing, maintaining the cold chain of insulin is important. Luckily, the newer pen devices are excellent. Most of them do, as long as you avoid direct sunlight, it should not be a problem. We would advise to use an ice pack, or the flasks you get, the thermos flask. You can make sure that you can keep the temperature close to the room temperature. That is one thing, maintaining the cold chain, because if you don't maintain a cold chain, then the insulin's efficacy can come down. Third thing, if possible, though I don't, if it's a leisure travel, again, carrying a glucometer would be advisable, because you don't want to risk with the dose adjustment. At least doing a one fasting value or one post meal value, you can accordingly adjust. And you know that having a masala dosa outside, obviously calories will be more. If you're on a regular dose of probably 18 and 10 units, a bit of titration can happen, plus 2 units in the morning. Especially if you're having this for your breakfast, you can do this. So these are some of the things you can do. And obviously, once you come back, it's even the levels, even if the levels are a little high, please come back and again monitor your levels, so that for the next 1 week after your travel, you can adjust the insulin dose and get back to the regular control you had. Only main advice is, please, if you're on a good dose of insulin, please don't stop insulin during your travel, because your glycemic control can actually worsen. And there is no replacement that I'm taking one tablet, can I make it 2 tablets instead of insulin? It can actually backfire without checking with your respective doctor. Some will diabetes. There's one more question. Yeah, okay. Again, Shankar Babu, can type 1 diabetes go for marathon? I have a lot of type 1 patients who actually do, a couple of them at least successfully have attended the annual marathon, which happens here in Bangalore. Yeah, it is. Yeah, I think that actually you can club with the second question with Madhusudan what has asked. So people, one thing in type 1, it's not that type 1 diabetes cannot achieve anything, and type 1 is not a factor to pull you things from what you like to do. But obviously, you need to be more careful. Obviously, your hydration is very important. Your monitoring should be more frequent. That is where your continuous glucose monitoring devices are really useful in people with marathon. But again, the risk of hypoglycemia is there. You need to adjust the dosage accordingly, and ideally, you need to plan at a time before the exercise. Obviously, you need to prick and need to have some sort of a replacement if your levels are low. And more important in type 1 is, again, the risk of ketosis or ketoacidosis. So your hydration is also very important. So make sure you're adequately hydrated. But just having type 1 diabetes doesn't put you at risk of not having a marathon. Again, as I mentioned, just like the travel, try to have a better control before you plan a marathon. Again, discuss with your doctor so that necessary dose adjustment is done during the marathon. Okay, there's other question. I'll try to skip some of the same overlapping questions. I'll try to cover most of the topics. Okay, there's something called liver cleanse, liver detox on YouTube. So again, with all due respect, as I say, like just we say, every chest pain, unless proved otherwise, is a heart attack. Same way, all social media, unless it comes from a reliable source, please don't. Just like the tick you get, right? Everything with a double tick in the social media, you get forwards. You don't have to take it on a face value. Some of these detox remedies doesn't work. Liver itself is a detox organ. You don't have to detox it with all those remedies, as long as you don't harm the liver with any alternative therapies, or with all the liver injury, what you call liver injury causing to liver, like your ethanol or even excess carbohydrates. Liver will take care of itself. So it's not you don't require any detox agents for the liver. Again, about intermittent fasting, 2 meal, 1 meal. So I think rather than doing 2 meal, 1 meal, have a fixed plan. And as I mentioned, first try to bring down your carbs. If you're able to achieve your carbs at 45 to 50%, then slowly try for 2 meal, one snack pattern. Again, one snack can be rich in your protein. But again, this again depends on your diabetes, what medication you're on, what changes can be made. This has to be again individualized. What may apply for X may not apply for Y. So that again, discussing with your doctor would have a better sense, rather than generally saying which pattern of intermittent fasting you can go. But obviously, most important is you need to be motivated enough to follow this. Will diabetes affect pregnant women? Definitely. I think this is a very important question. We all know the gestational diabetes, but even people who are planning pregnancy, just like you get your routine pregnancy tests before once pregnancy is confirmed, my sincere request is please get a fasting blood glucose and an HbA1c done. Especially people nowadays planning later pregnancy, risk of PCOS, obesity. Sometimes even if you're pre-diabetic, by the time you enter 24 28 weeks, because of the hormonal changes, you can develop gestational diabetes. Why is it important? Because nobody likes to take medications or insulin, but the pregnancy targets are extremely stringent as compared to type 2 diabetes. And if you start with a proper medical nutrition therapy or a low carb diet in the first trimester itself, especially if you're pre-diabetic, your risk of progression also comes down, or you may require very minimal medications or insulin even if you are diagnosed with gestational diabetes. And as we talk about organogenesis, the first trimester is extremely important in determining the damage for the baby, as well as the organ formation. So assessing your glycemic status at pregnancy or even before pregnancy is extremely important. Rekha has asked some question. You're not complete. Sir, can you please brief some MEMB? I'm not able to get it. If you can retype the question, I would be happy, Rekha. Some members are stuck during the weight loss process. Is there a weight loss plateau, especially during a controlled carb intake? Yeah, that is always there. Even if you're on certain the weight losing drugs like the SGLT2 inhibitors and GLP-1 analogs, you would have around 3 to 4 kgs weight loss initially. Then there is a kind of a plateauing. Body also will try to have a compensatory mechanism. So even if you're able to sustain that and at least prevent bit of weight gain, even that 3 to 4 kgs of weight loss will have some benefit, and that not only applies just for the drugs, even with your low carbohydrate diet. So there is definitely a plateauing, but obviously you cannot push in too much, right? Otherwise, what is required for the body is also you will not be able to give it. So kind of plateauing does happen. I have the same question as Rekha's weight loss plateau. So there will be a plateau, and that is where you need to somewhere tweak. If you're planning of somebody who's already diabetic, using some of the drugs which can cause weight loss will also have an added benefit. Because if you're thinking in the lines of remission of diabetes, you need to know the right combo of drugs. Initially, you need the help of these medications along with a diet to have some positive benefit, because it's not an assuming that you're on a drug, but these medications do have some sort of a positive benefit on your beta cells also. So using the right combination of both the medications with diet as well as exercise is extremely important, and sometimes helps you to cross that plateau, and you will have that extra 2 to 3 kgs of weight loss. Continuous glucose meters are great to have, but very expensive. Any other way to monitor the blood sugar continuously without? Yeah, so that's an excellent question again. So I would love to have CGM for all our patients, right? So CGMs are excellent. As I would echo Madhusudan's thoughts, but I would see the other way in our history, right? When we started out with the history of CGM, the Medtronics, when they started up, it was initially you had 3 days, 5 days. So something now today we have Libre and Libre Pro and the Libre 2 and 3 in certain countries. At least 14 days is a boon, especially for many type 1 patients. Bangalore is a place of all startups. So I would be very happy if a lot of techies who are seeing, if you're able to come up with the Indian CGM devices, which can be cheaper. I think many are coming in the market over the next 2 to 3 years. Definitely CGMs would be there. But since we are the startup capital, I think it's up to you people to take up this as a challenge and come up with CGM devices which are a little more cheaper. I think as the competition increases, the prices would come down. Just like initially when glucometers were introduced, they were quite big. Obviously, the numbers were less and even the price was more. Today, you have glucometers as less as even 1,000 rupees. So I think that would definitely benefit. And if CGMs becomes cheap, I think definitely it is the choice for all of us to monitor the blood glucose. Yeah, that's the same question. I think Madhusudan has the same thing regarding the weight plateau. Right. It's very challenging. Initially, you will have that the 6 months, 9 months, you can kind of have that enthusiasm, but somehow you need to motivate yourself and have some realistic target. Even 1 kg of weight loss or 2 kgs in a month or 45 days would definitely give you some advantage. uh, any latest technology in diabetes management? Definitely we have a lot of advancement. Not only as I was talking about the continuous glucose monitoring, I think that has definitely changed in managing diabetes in a lot of people, especially if you talk about type 1 diabetes or even type 2 diabetes with brittle diabetes, because you're able to monitor and track. It's even without the need to prick, because the conventional way of asking people to prick in glucometers, they'll have this inertia, be pricking 3 to 4 times in a day. These relatively painless devices almost gives you close to 90 to 100 readings in a day. And sometimes just fixing the devices won't make sense. I think fixing a device, having a proper dietary plan, maintaining a food log would definitely give you a lot of advantages. Sometimes it's even it will help you people to understand that what food generally causes a spike, because no two people respond to the same food. I mean, we have a different response to each carbohydrate. So you would know that, okay, I'm eating so and so food, my requirement is generally this spikes for me. So if I can modify, a simple example I would give is, if you talk about poha or aulakki, subtle changes by including some, squeezing a lemon or including some peanuts, because peanuts, again, healthy fat, would try to combat this. Or if you're having poha with some amount of green gram or a Bengal gram or a chana, the protein intake, if you can include there, that kinds of, and these inputs are basically, when you're on a CGM, continuous monitoring devices, you would be able to have this idea which food causes what kind of spikes and what necessary adjustments I need to make. Another advancement is obviously, yeah, if you talk about the insulin, you do have. We have seen in the 100 years, we have definitely seen insulin from starting from the animal insulin to human insulin. Today, the insulin pen devices, there are smart pens today, which actually would be, I think, soon will be available in India too, which will help you to the dosing as well as a feedback with the monitoring. Even the monitoring glucometer devices have had a lot of advancement nowadays. Even the accuracy is better, and the prick is much smaller than what it used to be. Glucometers can act as a continuous glucose monitoring devices. If you use those apps, it gives you a kind of CGM kind of graphs and the time and range, which are very important information. Last but not the least is your insulin pumps. And at least for affordable people, insulin pumps for type 1 diabetes is a boon. And if you talk about the latest, the 780G is almost like an artificial pancreas. It kinds of maintains the time in range close to 90%, which is unimaginable in some of the type 1 patients. In spite of being on 3 to 4 insulin pricks, maintaining a good glycemic control is extremely difficult for them. There's one question from Nitika Sharma. Okay, one of my relative had diabetes, is no more right now because of heart disease. Will diabetes might be a reason? If so, why, sir? Uh, so yeah, that I think you would. People with diabetes are definitely at a higher risk of cardiovascular disease or the heart diseases. But the idea is today, not only diabetes, even pre-diabetes, that is HbA1c between 5.7 to 6.4 itself is a risk factor for heart diseases. And the main concern is, as I mentioned earlier, the abdominal obesity is an important factor. And abdominal obesity, along with sedentary lifestyle, be it sitting in same place for more than 30 minutes, smoking, or high consumption of refined carbs, definitely puts you at a higher risk for atherosclerotic cardiovascular disease. And as much as we talk about HbA1c, even today, you do a normal fasting lipid profile, you would see majority of the people, the LDL or the non-HDL cholesterol being on the higher side. So sometimes it can be, you never know. So it's sometimes it's not about getting the test done. It's important you can screen earlier. At least if you screen earlier, because any of these changes, if you talk about if somebody is developing a heart disease in 40s, the changes begin in 20s. So it's very important you start things early, and inculcating these habits even in the teenagers or the school going children is extremely important. And that definitely has an advantage in preventing both diabetes as well as the cardiovascular disease. So heart disease could be one of the reasons, but it's very difficult to tell. But people with diabetes are definitely at a higher risk of cardiovascular diseases. Okay, there's one more question. Which food or vegetables are extremely dangerous and best to be avoided for diabetics? Veggies, I think, it's nothing more dangerous. It's about, again, balancing your carbs. I think it's more easily said than done. But definitely, I would, some of the important ones which we see is the direct sugars. Anything with your direct sugars would be harmful, but it doesn't mean that you can. Even when people talk about sweets, I think, the festival, we just got over a couple of festivals, and there is always this tendency: can I have this sweet during the? Can I have a sugar-free sweet? But again, as I mentioned, moderation is the key. And even if you're having a cheat meal or some sort of a diet, more carbohydrate, excess calories, if you're able to burn it, and if you can little spend more time in burning those calories, if you can slightly increase your physical activities on those days, definitely that will have an added advantages. In among the vegetables, I think most of the vegetables you can consume. People do talk about restriction with your potatoes. Sometimes people have confusion even with carrot and beetroot. We talk about the glycemic load, but in general, again, in moderation, if you consume, it's not a major concern. Most of your vegetables can be consumed. Only concern is it's about you make sure you rotate it so that you don't get bored with the same vegetable and you reach a plateau and you tend to have a cheat meal next day. One thing I would probably stress here is, since you mentioned danger foods, especially in the last 1 year, there's a trend of people having these porridges, the health mix, especially millet mix and health mix. They consider this to be kind of the superfood, which gives them energy. And the biggest surprise is they replace their coffee, tea with this porridges. And the problem is, anyone for that matter, not only just diabetes, a liquid diet is generally not advised whenever you have a liquid diet. And again, these are loaded with calories. Even a 200 ml of any of your health mix would have around, irrespective whichever millet they are. And we have shown in our studies that even millets are equally have a high glycemic index as your other counterparts. So again, having multiple millets would have a higher calorie intake. And again, when you have them as porridges, they would have a sudden steep spike, and then the levels come down, and they would have a second breakfast at around 10:30 or 11. Again, the routine, instead of having three idlis, they tend to have one or two idlis. So basically, you're having more of a double breakfast. You tend to actually gain weight rather than maintain your whatever ideal weight is. Or if your doctor has asked you to lose some kilos, that may not happen using these health drinks. So avoid any sort of food. Try to avoid a liquid diet. Whatever you eat, try to chew well and eat, and have equal amount of vegetable or healthy protein. Third thing, I think, since we are talking about weight and obesity, third common thing which we come across is what others feel about us. So generally, people would complain. People are saying that I've lost weight. Should I? Should I? I want some medicine which can actually make me gain weight. So my question is, if you're already having an ideal weight and you've struggled hard to lose 2 or 3 kgs, forget about what others are saying. People would talk, even if you're a little on a higher side or lower side. You may say that you're on, but why you lost weight is more important. If you had an unhealthy weight loss, definitely it's a cause of concern, and that needs to be evaluated. But if you lost weight consciously and you've worked hard for it, it's very easy to gain weight. Again, gaining 1 or 2 kgs is not a problem. So what is your ideal weight is very important parameter. And other metric is, whatever is your height. Easiest way of asking is, uh, whatever is, if your height is 170 centimeter, 170 minus 100, around 70 kgs is your ideal weight. So most of you can definitely calculate your ideal weight. And as I mentioned, the other parameter is your waist circumference. So just don't look at weight per se. Also look at the waist circumference and try to maintain those cutoffs. What I mentioned, that is 90 centimeters for that is 32 inches in case of males, 28 inches or 80 centimeters in case of females. Now, I think one more question is, what is the latest time to have your last meal? I think if you are following a 3 meal pattern, I think by 7:30, 8 o'clock, ideally at least 1 or 2 hours before you sleep, at least 1.5 to 2 hours earlier, you need to sleep. Please don't have at 10, 10:30, 11 o'clock and sleep next within 15 minutes. Apart from just disturbing your there's a diabetes cycle. It can also disturb. You can have your reflex, the gastro GRD, what you call. So it's very important you have at least 2 hours gap between your meal. So anywhere between, if you had your lunch by 1:30, 1:30, then maybe 7:38 should be ideal for you. Try to maintain a set pattern, and again, having a small short walk, 10 to 15 minutes of walk with each meal will also have some sort of an advantage, not only just to control your diabetes, but also to balance your calories as well as the amount of calories you're burning in a day. Few more questions I would wait for, then probably I'll summarize by today's talk. I think most of you have asked, most of the questions have been answered. I just look out if any questions have been missed. I think I've answered. Thank you. There's a excellent session. Thank you, Nitika. But I think we are almost to the end of the session. But I'll to put all this perspective together. I'll try to summarize, and we'll have a take-home message. But as I mentioned, the first and foremost important thing, uh, the obesity classification, or what we call as obesity, varies for Asian Indians. Definitely, Asian Indians have a more strict cutoff, not to make them more obese, but obviously because of the cardiovascular, both cardio and the risk of diabetes. So in Asian Indians, the BMI, as I mentioned, is between, any BMI more than 25 is obesity. Obviously, obese people definitely have a slightly higher risk of diabetes. Agreed, it is a danger sign, but the light at the end of the tunnel for the obese people is, as I mentioned, in the subtypes of type 2 diabetes, if you can have a healthy weight loss, definitely you have a higher chance, slightly better chance compared to other subtypes of diabetes in the remission of diabetes. But again, you need to have a, what you call, a proper combined approach for them. Because when you talk somebody with a lean type 2, you cannot ask him, please lose some more weight, your beta cell function may improve. It can actually backfire. So obviously the obese or the resistant subtype would have better chance for remission if the duration is lesser, and if you're able to have a low carb diet. So that is one thing. Third thing, even if you're lean, definitely your risk is there. So it's not that only people with obesity would have diabetes. Even with lean people can have. So BMI is one of the factor. Apart from BMI, as I mentioned, the waist circumference. So the other important goal for people who are thinking of weight loss or maintaining a healthy weight is the waist circumference. So try to maintain the waist circumference, or try to avoid increase in your waist circumference, because that can have a negative effect, not only just for your diabetes, but also for your heart diseases, which I mentioned. So that is the third important factor. Fourth thing, diet plays extremely important role. Exercise is good, but diet is more important. Some may not exercise, but still, if they are able to follow a proper diet, they may not gain weight. But if your diet is bad, definitely, in spite of whatever exercise you may do, you would definitely gain weight. And as I mentioned, carbohydrates in general plays a very important role. And consider all your cereals to be carbohydrate. Don't give any special importance to the millets, and don't play down the rice, because again, brown rice, again with a lot of vegetables, is again a good alternative. So it's nothing to do. Whatever is your staple food, try to follow a balanced approach, but make sure every meal has excessive vegetables as well as adequate protein in them. Last but not the least, definitely with the advancement of medications as well as the technology, you can definitely, when you're using a approach for if weight loss, using certain medications which would cause healthy weight loss, like the GLP-1 analogs or an SGLT2 inhibitors, along with diet, a combined approach would definitely have a better result in not only having a weight loss, but also to prevent your future risk, both for your diabetes as well as your cardiovascular diseases. So it's very important you individualize, and it's very important you discuss with your doctor before having this plan, even if you're talking about remission and reversal, so that you will be able to do it. And any plan should be able to sustain, even if you're not on medications. If you're on diet and exercise, it's important you follow up once in 3 to 4 months, because there is always a possibility of re-reversal if you're not able to follow these targets. And as I mentioned, most of you can be asymptomatic. Sometimes if the HbA1c doesn't go about 10, you may not have any symptoms. Not that everybody will have increased urination, thirst, or increased appetite. So this doesn't happen for everyone because the presentation can be heterogeneous. So that is something which you need to keep in your mind. Very well explained, sir. How can I contact you? So I'm available in the Malleshwaram Center. Down, I think the center, the contact numbers are there. Our team would definitely help you to fix an appointment with us, and we are always there to help you people. And those who are already my patients and were following up, thank you for joining in. I think one last question is from Soundarya Nair. Thank you for a wonderful session on weight management. Does everyone with PCOS will get diabetes? Because PCOS itself leads to abnormal weight gain. So it's kind of an interlink. So what you call the PCOS, again, the common risk factor there is your insulin resistance. So again, it's not that obviously obese people will have increased resistance. Again, insulin resistance would lead to the hormonal disturbances, definitely would disturb your the cycles. So it's not that PCOS means you would get diabetes, but definitely you're at a higher risk because your marker of your insulin resistance, like your acanthosis nigricans, your what you call increased insulin resistance, would definitely put you at a higher risk. But again, the light at the end of the tunnel here is if you can again lose weight, again a healthy weight loss, both the risk definitely gets negated. So definitely you can work on it. It's just that just because you have PCOD doesn't mean you would get diabetes. Thank you. So very informative, sir, about diabetes and weight management. Thank you for the informative session. So I hope the session was useful. I think any more doubts, I think probably you can put in the chat box, and if you are willing to consult or meet me, I think definitely our team is there to guide you. I think the number is visible, is being displayed there. But all I would tell is definitely don't consider obesity has to be treated more strictly. I think you need to inculcate not only just for the teenagers, but it has to start on early stage. I think preventive measures in all these factors, what we discussed over the last one hour, would definitely help you in not only just preventing diabetes, but also the other related complications. Thank you.